Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Simplifying the Complexity of Dry Eye and Ocular Surface Disease, live question and answer session with Dr. Art Epstein. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them throughout tonight's live question and answer session. Our speaker tonight is Dr. Art Epstein. Dr. Epstein is a native New Yorker who grew up in Bronx, New York. He received an OD degree from the State University of New York State College of Optometry, where he also was the college's first resident in ocular surface disease. After relocating to Phoenix, Dr. Epstein co-founded Phoenix Eye Care. He heads the practice's Dry Eye Ocular Surface Disease Center, the Dry Eye Center of Arizona, and serves as its director of clinical research. He is an adjunct associate professor at Midwestern University Arizona College of Optometry. Active in his profession, Dr. Epstein is a fellow of the American Academy of Optometry and a distinguished practitioner in the National Academies of Practice. He is a diplomat of the American Board of Certification in Medical Optometry, a member of the American and Arizona Optometric Association, and past chair of the AOA Contact Lens and Cornea Section. Dr. Epstein is a prolific author who has published hundreds of articles, scientific papers, and book chapters. He is a contributing editor for the Review of Optometry and executive editor of the Review of Cornea and Contact Lenses. He founded and serves as chief medical editor of Optometric Physician, the first and most widely read e-journal in eye care. Dr. Epstein is a reviewer for numerous clinical and scientific journals, including Cornea, Eye Contact Lens, and the American Journal of Ophthalmology. A sought-after speaker, Dr. Epstein has presented in excess of 1,250 invited lectures on a variety of topics nationally and in more than 50 countries across the globe. Welcome, Dr. Epstein, and here is our first question for tonight. To start off the conversation, could you describe your practice?
I could. By the way, I apologize. We've used half the time on the introduction. So there's a short one somewhere. So I apologize for that. It's actually embarrassing to hear all the time you spent doing all kinds of different things and you go, where did all that time go? So my practice is kind of interesting. I practiced in New York City for many years, or New York City area, I should say. And I guess probably about 8 years ago, 7.5 years ago, my wife and I decided that we wanted to be entrepreneurial. We opened a practice. She came up with the name Phoenix Eye Care, which still to this day amazes me that it was available. And I had this brilliant idea of creating an ocular surface disease dry eye center, thinking that there'd be 1 million people doing it. As it turned out, virtually no one was. So my practice at this point is completely limited to ocular surface disease and dry eye. It's largely referral based, so we're very fortunate to get a lot of referrals from the community, OD and MD, and we also have a large number of patients who refer to us as well. So all I see is dry eye, with the exception of emergencies. Occasionally I'll take an emergency call. And it's great practice. You know, we learn things every day. So anyway, you don't want to hear about me. Let's answer some questions.
Okay. So we had a couple of questions submitted prior, so here's a few questions for you. Have you ever used punctal plugs as temporary adjunct therapy while treating Meibomian gland deficiency to boost tear film retention?
So that's a great question. I almost never use punctal plugs. Sorry to the punctal plug companies. And we've had, tremendous success. We have, 98% success with really complex patients. And the reason why I don't use punctal plugs is I don't find them very helpful in any capacity, with rare exceptions. There are some rare exceptions. Essentially, I look at dry eye, and I'll put that in quotes, as dysfunction of the tear film, not insufficiency. I think we're so wedded to this concept that the tear film is, insufficient, that we want to maintain tear volume through any means, whether it's adding artificial tears or using punctal plugs. But I philosophically find that all it does is it creates a cesspool and doesn't help. Now, there's people who disagree with me, but and I certainly respect their opinions. But what works for me, and I'm willing to share what works for me, works for me. Oh, by the way, I should add, to keep everyone safe, in this environment, all the opinions expressed are my own opinions, and I'll try not to offend anyone, but I pretty much say exactly what I think. So hang in there and let's keep going.
Can you talk about scheduling your different procedures, your initial evaluation, your follow-up visits, and your frequency of follow-up visits?
Yeah, that's also a very, very good question. The key to success in creating a dry eye practice, and a lot of people say, I really want to have a dry eye practice, and how am I going to schedule patients in my 20-minute slots or my 15-minute slots? And it's impossible. The key is patient flow. That's really the essence of the equation. And our model, by the way, is used in a university eye center on the West Coast. It's used in a very successful and very well known practice on the East Coast. Literally emulated exactly what we do. All new patients are scheduled for an hour. And again, I'm not seeing routine patients. I'm not doing routine eye care. I'm just seeing patients who have dry eye, doing specific dry eye testing, which I guess we'll probably touch on in a bit. Patients who they're seen, I go through, a typical process. Everyone has about 10 to 15 minutes of testing done by a technician. And then I spend about 45 minutes, sometimes even a little longer, depending on complexity with the patient. I know people are going, oh my God, how do you make any money? Trust me, it's very profitable if it's done properly. Then patients are seen at different times. We'll schedule patients, for example, for IPL in 15-minute slots, patients for follow-up visits in half-hour slots, and so everything is kind of orchestrated for patient flow, and it works quite well.
Kind of to go along with the IPL that you just mentioned, which treatment do you prefer? Do you prefer intense pulse light or low light therapy? And is low light therapy being considered for management of dry eye and Meibomian gland deficiency?
Well, I think low light therapy is, as the Brits would say, bollocks, or as we would say in America, garbage. So I know there's a lot of talk about it, and I apologize to Marco. There's literally one article written by a consultant for the company discussing low light therapy, and I know they're trying to co-opt the photobiomodulation message. And I know some people are using it supposedly with good success. I don't see the science behind it, and I just don't see it. That doesn't mean my mind doesn't remain a little open to it. Right now, I'd say we're probably doing 75% IPL, and the rest is a mixture of tear care and LipiFlow. Tear care is great for someone starting out because of its low cost of entry, and it's very, very effective. Also, it's more hands-on, so it's easily controllable. Higher volume practices, LipiFlow works really, really well. But I love IPL. I think IPL is great. Not for reasons that I think a lot of people think, which is heating the glands, which it doesn't really do, but it does change gland function in a fundamental way, and we've had just absolutely phenomenal success with it.
Thank you. So, which tests from the keratograph do you incorporate into your dry eye workup?
Right. So I love the keratograph. I said before we went live, I said if I hadn't purchased the keratograph 5M as one of the early purchases in the practice, I don't think I'd be where I am today, because it not only allows me to better diagnose patients' problems, but also to communicate with them. So it's an amazing communication tool. So meibography is critical. We do meibography every single, I shouldn't say every single visit. Actually, we do have follow-ups where we don't, yeah, we do have follow-ups where we don't do meibography, but we do meibography very frequently, at least once every 6 months, would be the absolute minimum. Non-invasive breakup time I absolutely love. It's different than fluorescein breakup time, but extremely valuable. Tear meniscus height, very, very helpful, much better than Schirmer strips, which I think is antiquated technology and philosophy, and very different than lacrimal lake height or tear meniscus height. Redness index is very helpful, especially with the increased number of patients who are coming in complaining of aesthetic issues, and we now have ways of treating it, like Lumify, for example, and also addressing the underlying disease that causes it. One of the top search terms in our practice website is actually, I have red eyes. What do I do? And being able to quantify it is very, very helpful. And we'll also use some of the other functions from time to time, but those are the primary functions we use.
Okay. And with the test results you get from the keratograph, we have somebody who's asking, how do you concisely and efficiently communicate the information from the K5 or from the keratograph to the patient?
Well, I don't know if I've ever been accused of being concise. I tend to be, I wouldn't say I'm verbose, but I like to use analogies and anecdotes, and I leave a lot of time for that. So for example, I'll explain to the patient. I'll give them I tell them they're going to get a PhD in dry eye, and indeed they do. I start out by saying, I know you think your eyes are dry, but in reality, it's not a lack of tears, but a deficiency of the tears. Which kind of begs the question, what do tears do? So I have like a kind of a baseline script. Obviously, it varies depending on the complexity of the patient and the specific reason why they're there. A lot of it's interactive. I think the patient is, super sensitive as an instrument. If you ask a patient, so, let's step through your day. Do you have dry eye first thing in the morning when you wake up? You have trouble opening your eyes. They feel like sandpaper. And the patient goes, oh my God, yeah, I can barely get my eyes open. In fact, the patient I saw last yesterday evening said, I don't even try to open my eyes. I have a bottle of artificial tears on my nightstand, and I literally flood my eyes to get them open. So a lot of what I do is basically give them some background. I typically have an image of their Meibomian glands up because I very rapidly get to the core issue for most people, which includes Sjogren's patients and rheumatoid arthritis patients. There's no way of making more tears at this point effectively. I mean, there are ways of increasing tear production, but it's not clinically relevant, at least in my opinion. But stabilizing the tears is more easily accomplished through managing Meibomian gland dysfunction, or I should say managing Meibomian gland function, and being able to show them what they're missing. You've lost about 40% of your glands. The keratograph has this great function where it shows a GenVis grading scale. So I can say, this is normal and this is you. And the patient goes, oh, and they understand that that's an issue. And then I explain that the lipid layer produced by the Meibomian glands creates not only an evaporative barrier, but also a stabilizing element to the tears. And then I explain that that's the reason why we see well, and that's the main reason why we have this engineering in our ocular surface environment. And then I show them non-invasive breakup time, and they see red, and they understand that the tear film is very unstable. So it's very, to the patient, I think they, especially I see patients that have seen 4 or 5 other doctors. I saw someone who saw 8 different doctors and traveled halfway across the country. I see patients from the East Coast as well. I see patients actually, from as far away as the Middle East. Giving them that information is really what makes the difference. And that's true even if you're starting out. If you can communicate, and again, I'll go back to the Oculus being a great tool for communication, it's the foundation of it. It really changes the dynamic. It gives the patient hope, and they have a sense that they will get better and that you care enough to share that information. If you have someone who has virtually no education and they don't understand the science or physiology, yes, you can't go into tremendous detail, but you very quickly learn to cater your explanation to the level that the patient is capable of understanding. If you have an engineer, expect to be there for 2 hours, but if you have a PhD, it could be even worse. But it's very rewarding seeing the patient would really transform in front of your eyes.
So
that was a long answer.
It's all right. So kind of speaking along that lines of, you were talking about patients that travel far to see you. What if you were referred a patient who's done everything? They've had doctors prescribe, they've done IPL, LipiFlow drops, everything under the sun, and they're still having symptoms. They're still sore, and there's psychologically they've just given up. What do you recommend?
That's a great question. Well, no one's tried everything. because there are always new things coming out, which is great. The other thing is that the sequence of things is very, very important. So I had a patient that was, referred to me by a colleague who, I think is tremendous respect for the person. And the patient had been treated, for recurrent chalazion and for other issues. And I kind of looked at it, and I didn't want to do the same thing that they had done. And I said to the patient, who was actually from, actually out of the country, like an expat, I said, you know what, let's go back to basics. We don't have a lot of time, and I'm going to give you a triglyceride-based omega-3 with a high EPA to DHA ratio. I'm going to give you hypochlorous acid and a couple of other things. And I go, I don't know if we'll have time to see if this works or not. I think we will get results, but at least let's get started, because I don't think the current path has been productive. You haven't had significant progress. Anyway, the guy comes back in a week and says, you've literally changed my life. I mean, this is the first time in 8 years that my eyes look good. This is the first time in 8 years that the acne on my back, which may sound weird, but some of the things we do have overall health benefits. He said, the acne on my back is clearing up, and I feel better than I felt in a long time. I was actually shocked. So that's, one example. The other example is there are, things that I pull out of my, from up my sleeve, like, Regenerize. And there's another product in that category now, which is amniotic fluid. We use an antioxidant drop, which most people don't know about. So there's a lot of things that we figured out that are not traditionally used. And those things are listed, by the way, on my, patient instruction sheet for the most part. Some aren't, some of the really esoteric things. And I share that with people openly because there's always something you can do. If you set your mind to taking it home with you and caring enough and making it personal and serious, my goal is to thwart Mother Nature. Mother Nature takes nice people and it screws them. And I don't like it, so I will do anything in my power to make them better and change their lives. And patients literally cry in the office. And it's not me. Literally everyone can do it. You just, get started, emulate me. People will say, oh, I use this, the same as what you use. No, it's not the same. And again, personally, there's some companies I like, and some companies that, I don't have a relationship. I don't dislike any company per se, but the stuff I use, I've tried a lot of things to figure out what works and what doesn't. And there are a lot of keratograph imitations, and most of them suck, frankly. I've seen them, and I've told companies, no thanks. So, and same thing, with omega-3s and things like that. It wasn't like I just jumped on board with these things because I like the person or like a company or something like that. To me, when I'm in the office, it's all about the patient. Anyway, I think I drifted a little here.
So someone was asking about those handouts, and I believe we already actually have them. So there's going to be a follow-up email going out in the next week with a recording of this webinar, and we can actually include that handout if Dr. Epstein, if you approve, we can actually include that handout in that email. So if you are interested in it, we can include that in the email as well.
That would be great. I have by the way, I have a very simple philosophy. I've gotten where I am today, in terms of patient care and knowledge, because of the generosity of other people. I think most people in healthcare believe that they should share knowledge. That's an important part of it. So, and I believe it should be shared freely. This is at no charge. My master classes are at no charge. I think knowledge should be shared freely, because you know what? There's a lot of people out there who will figure out what I've done, get better at it, and share it with me. So, it keeps on giving, it gives back. So happy to share whatever resources I've developed and I have.
All right, it's much appreciated. Thank you. All right, do you utilize scleral lenses for dry eye, and when do you implement these fittings during the dry eye treatment protocol?
Yes and yes. No. Actually, my other half, my wife, actually is the scleral lens expert. She's just absolutely brilliant at it. And when we first opened the office, I, had a tremendous background in specialty lenses. So I was obviously the specialty lens guy. We didn't have enough volume in the dry eye practice to occupy me. And I very rapidly discovered that she was better at it than I was. After all those years, she called me in to look at a I think it was a Rose K fit, and it was some bizarre Rose K, toric, I don't know what it was. It was something really crazy. And I said, guess what? You're the now designated contact lens hitter. So we do use scleral lenses. To me, it's kind of a last resort, but it's a transformative last resort. And again, it's a last resort because I don't want to give up in simpler things. I want to interfere with the patient's life as little as possible. But again, just yesterday, I had a woman who came in very upset about COVID and the impact on her life, and almost started to cry. And then when we went through the exam and we talked, and she was looking great, and she said, you literally, changed my life. And it was the scleral lenses. I think that was the icing on the cake for her. And scleral lenses have incredible power for these patients because it creates an artificial separation between outside environment and ocular surface, which is essentially what the tear film should be doing when it's functional. So absolutely, yes. Patients referred to my wife. The scleral fitting is performed, and then I'll share the patient with her.
Okay, so most patients have both evaporative and aqueous deficient dry eye. Do you recommend that those patients be put on both lipid and aqueous artificial tears?
No and no. Most patients don't have aqueous deficiency. Very few patients actually have aqueous deficiency, probably 1 or 2% of the population, if that much. I think that's a misconception brought about by historical bias that dry eye is actually dry. Dry eye isn't dry eye. Dry eye is an instability of the tear film, which is a structural element. It's essentially an engineering problem. So there are some patients who need additional tear volume, and I'll use something like Sustain Ultra, which I still think is a phenomenal drop for someone who doesn't need more lipid, which is rare. But we use a tremendous amount of Allergan's Mega 3, which I think is best in class of the lipid-containing drops. And again, drops to me are really tertiary. If you're doing things right, patients will start telling you, I'm using drops less and less. That's a good indicator of your success in getting them back on track. But I think that the concept of aqueous versus evaporative dry eye is really antiquated. It's a continuum. Because how do you tell the difference between evaporation and lack of production? We can't measure production. I know you're going to say Schirmer's, but Schirmer's doesn't measure production. So, the answer is whatever the patient chooses. If they're happy with it, I'm happy with it too. And if they use less of it, I'm even happier.
Perfect. All right. Do you have a favorite hypochlorous acid? And if I have them clean eyes with We Love Eyes brand tree oil, should they also use that hypochlorous as well?
That's good. That's actually a good question. So actually, I use HighClear, gethighclear.com, www.gethighclear.com, no financial interest. It's actually made by Contomac, and what makes it different than most is that it's a newer generation stable. So an open bottle will last for I'd say about a year and a half, whereas Avenova, which is the granddaddy of hypochlorous acid products, will become unstable very quickly, and what doesn't even last a month once it's open. So I think that's one differentiation. There's a lot of companies that make products. Some of the companies, and I'm not going to get into naming names, but I don't use We Love Eyes. Some of the products have been tested by some of the other companies, and I'm privy to that information, and the concentration of hypochlorous acid and stability is less than optimal. So, if you're going to use products, I would say, either use HighClear or use Avenova. Those are two solid, reliable products. And there are other products that are kind of similar, but you'd have to really figure that out. I don't use a lot of tea tree oil. When patients obviously have Demodex and have collarettes, I will use tea tree oil products. I typically recommend iEco gentle tea tree foaming eyelid cleanser. Very low levels of tea tree oil, but enough to deal with Demodex, and I find it very efficient. But that's really, in Arizona, it's a small percentage of my patients. If you're in South Florida, you may have a lot of patients with Demodex. It does vary geographically, so you don't need that much tea tree oil. And by the way, IPL kills Demodex as well, so that minimizes that as an issue.
Okay, thank you for that answer. All right, so do you think omega supplements should include all three, DHA, EPA, and GLA, or just the DHA and the EPA? What do you find the most important?
And that's a very, very good question. The DREAM study was interesting. We all, sat on the edge of our seats waiting for the results of the DREAM study, and we were all shocked. I mean, not all shocked. Some people, I'm sure, were saying, "Oh, see, I told you, it's the same as olive oil. It makes no difference at all." But I think most people really were aware of the benefits of omega-3s, recognized that there was something seriously wrong with the DREAM study. And I think what was seriously wrong with the DREAM study is that the formulation they used was a 2-to-1 EPA to DHA ratio. I find GLA not only has no value, I find that it has negative value, at least in my experience. Now, I do have patients that occasionally come in and say that I'm using a GLA-based product and, it's better than what I've recommended, which is a triglyceride-based omega-3 with a 3-to-1 EPA to DHA ratio. But the vast majority of my patients do extremely well with high EPA ratio triglyceride-based omega-3. Most omega-3s available commercially are ethyl ester forms, which are not absorbable very well by humans. So my experience is EPA is key. We did a study probably about a year and a half ago looking at a pure EPA formulation, which was not easy to source and very difficult to make for the company that produced it. In fact, too expensive for us to actually buy enough quantity to justify having it. I would have had enough for 5 years worth, but the response of patients and the results that we had in tear film stability, lipid layer thickness, and other metrics was so positive that I'm convinced that EPA is the essence of the equation. GLA can actually destabilize. It actually, in my experience, when patients take additional GLA, it actually destabilizes, the EPA primarily. And there is obviously some DHA in most formulations, and there's typically there's more DHA. Well, I shouldn't say it depends on the formulation, but DHA is usually a major component. DHA is useful for structural issues. EPA is more anti-inflammatory and is essentially the raw material that the glands use to convert into meibum. So I'm an EPA guy. Put me down for that.
All right. Okay. So I have been treating, or doctor is asking, I've been treating Sjögren's with IPL and scleral lenses. What's your opinion on using IPL for Sjögren's?
Sjögren's, yeah.
Sorry.
Actually, I think Sjögren's is hard to pronounce. You look at it, it's like one of those tongue twisters. Sjögren's. So. But Sjögren's, what Sjögren's basically is it's an autoimmune disease that attacks the moisture-producing glands of the body. Among them, the lacrimal glands, which is usually a fairly consistent presenting sign of most, but not all, patients who have Sjögren's syndrome. It was really the first dry eye condition that was investigated by Sjögren in the 1930s and described as a dry eye condition with obviously other concerns. So scleral lenses make perfect sense. Again, not necessary for every patient because you can manage those patients. My goal with Sjögren's patients is to increase tear stability, because again, if you have a tear film that's this much, that's this thick, then you have a lot of leeway if you have evaporative issues. If you don't have sufficient meibum, both from an evaporative barrier and a structural perspective, and then you have buffer. Let's say you lose this much over the course of a day, they still have this much. But if the patient is aqueous deficient, as Sjögren's patients are, and again, when I say aqueous deficiency is very rare in Sjögren's patients, obviously it's part of the diagnostic presentation or part of the disease presentation. So you're starting out with a relatively shallow amount of actually gel forming mucin aqueous coacervate, and then if it evaporates, boom, you get exposure very, very quickly. So your goal with a Sjogren's patient is to produce enough competent lipid to create a cohesive outer barrier and stabilize the tear film. And IPL is a great way to do that. When we look at lipid layer thickness using interferometry, you can also assess quality of the lipid through the imaging of the interferometer. And I do know that IPL, from a lot of experience, improves the quality and also improves tear film stability. So I think IPL is a great way of dealing with Sjogren's. We've also had good success with expression. Again, a lot of my experience early on was with LipiFlow, and one of my probably the most momentous patients I ever had was a 20-year Sjogren's sufferer who came in with wraparound sunglasses and agony, and it was every time a doctor came on the scene who was doing dry eye, she went to visit him. I ended up doing LipiFlow on her, which had not been tried before, and literally she started producing lipid, literally transformed her life. And the last time I saw her, about a year and a half later, she wasn't even wearing wraparound sunglasses and was able to play golf and get back to life. So I mean, reinforcing normal tear film function and stability is key to those patients. So what you're doing makes perfect sense.
And then the same doctor, as a follow-up question, asked, do you use the SJO test with them as well?
I do, not quite as much as I did in the past, and the reason is, if it looks like a duck and quacks like a duck, and swims on a pool like a duck, 99% of the time it's a duck, unless it's a pigeon that's demented or something like that, or a pigeon that grew up with ducks maybe. But you don't really get a lot of information when a patient clearly has all the signs and symptoms of Sjogren's. I offer the patient the option, do you want the test? It's a simple, relatively straightforward test. The main value of the show test is that patients who have Sjogren's have a significantly increased incidence of lymphoma. And if you're not sure if it's Sjogren's, or if the patient wants definitive proof, or they're suffering from more than dry eye, and you want to refer them to an endocrinologist, then the show test can be very, very helpful. But I do order it a lot, but I don't order it quite as much as I have in the past. If they quack.
I just wanted to All right, I just wanted to remind the audience that you do have on your GoToWebinar screen, there is a text box where you can enter questions. We're about halfway through, so I just wanted to remind everyone that you can enter questions still. And our next question is, have you personally observed regeneration of the Meibomian glands using IPL or Regenerize?
We actually have a very astute audience, so very, very, very impressed. So I tend to approach things in multiple layers. So it would be nice if I could tell a patient, well, I'm just going to use, say, Regenerize, and we'll see how it goes, and do nothing else. And you really can't do that, because if I'm at the point where I'm using Regenerize, which is quite expensive, and it's not something that I'll casually prescribe. It's a thoughtful prescription. I'm usually doing it with a number of other things. So and this was probably about 6-7 years ago, we saw significant gland regeneration in one patient at first, and then in several others. And I mentioned it to Donald Korb, and he said, no, it's impossible. I said, Donald, I'm seeing it with, literally with my own eyes. And I published some pictures in Optometric Physician of before and after, and he was, almost cute. He said, "Are you sure that that you didn't confuse pictures?" So so there's no question that I have seen regeneration, and I've seen regeneration that I associate with Regenerize. It's not consistent. I've definitely seen, we had just recently an IPL patient where we had an area that was devoid of glands, and on the follow-up had a significant amount of gland regrowth or reappearance or regeneration, however you want to put it. To me, the most important thing isn't necessarily gland presence. I know patients are always concerned about that, but I'm more concerned about, how does the patient feel? how stable is their, is their comfort? How much better is their comfort? And what's the data showing? Is their lipid layer thicker, and is that more consistent? Is their tear film more stable? Non-invasive breakup time is more stable. It's more green and than red, and it was red initially. So I'm more interested in, number one, patient's perspective on how they're doing. Number two, data. And then when I'm seeing regrowth of glands, I'm going, wow, that's pretty impressive. There's additional growth, but it does occur. I'm convinced that it does.
Okay. What is your opinion on radiofrequency partnered with IPL for the temperature component of treating Meibomian gland deficiency, and why did you choose LipiFlow over radiofrequency?
Well, that's again, great questions. So the reason why we chose LipiFlow initially is that it was the only game in town. There really was nothing else. I had a good relationship. I've consulted with. I've been very fortunate. I've had access to technology early on, so I consulted during the development of LipiFlow, and when we opened the office, we were in massive debt, and I said, well, we'll put that off, and probably about 2 months later, send me a LipiFlow, which back in those days was like $100 grand. I mean, it was a lot of money. So we started with LipiFlow because it was the only thing that was available. As far as IPL, I was very hesitant to get involved with IPL, simply because the reasoning was actually relatively straightforward. IPL was first discovered in terms of its efficacy with dry eye by Rolando Toyos, and Toyos believed that it was heating of the glands, or apparently believed. I don't know. I've not discussed this with him, although I do know him. We've not had this discussion, but the fact that he recommended expression afterwards didn't make a lot of sense to me, and the data wasn't really there. And then we started to see a lot more data coming, and Laura Perriman, who I think is quite brilliant, was a big fan of it, and she was very willing to share her perspective, and we kind of embraced it, and then had phenomenal results with it. So at this point, we primarily use LipiFlow and Tear Care, which I like a lot. It's a really good system. We also have iLux. We pretty much have everything, but we don't use it as much. My associate likes iLux a lot, so I do think that's a viable technology as well. But most of what we're doing is IPL. We've looked at RF. Unlike LLLT, which I at this point don't see any science to support. I think RF does have some science. LipiFlow, IPL is not about heating. IPL is about applying packets of energy in the form of light. So the light is an envelope for energy. The energy stimulates gland activity through, on a cellular basis. On the skin, it stimulates fibroblast activity, which lays down new collagen, sterilizes, regenerates gland tissue, increases lipid layer thickness and stability. I mean, so it has a lot of things that it's doing, I think, through photobiomodulation. I think the process actually is on a cellular component level, and NASA's investigated this. So there's a lot of evidence, tons and tons of studies. RF is really, to me, a more simple heating approach. So it's another way of applying heat. The benefit of LipiFlow or Tear Care is that it's very limited, so you're not going to get into trouble, and you can have a technician do it. The concern about RF at this point, and again, we're just beginning to look at it, is that you can cook someone. I mean, RF is what makes your microwave heat up your dinner, and I have this nightmare that the patient calls up the next day and looks like one of those complications that you see on Google when you Google like IPL complications, when some lunatic sets the fluence to 100 rather than 10, and the patient's eye sockets are cooked. So we're going to definitely look at it, but we're going to approach it very, very warily. One last thing: every state is different. If there's contact with the skin, penetration of the skin through electrodes, that becomes an issue in some states, including in Arizona. We've already been told by the board that you penetrate, no. It's a no. So check with your state board. IPL is a yes, and certainly LipiFlow and Tear Care are yeses.
We have somebody in the audience who's asking, what is your IPL protocol? And do you get close to the eyelid margins? You do a double pass?
Yes,
Can you
good question. So we started off like most everyone with using a Toyos pattern. We use shields originally. They were Honeywell shields. Now I forgot the name of the company. Honeywell stopped making them for reasons that is totally beyond me. Actually, these shields I think I like a little better because they're a little better at shielding. I actually have, I always called it a modified Toyos pattern, but our rep calls it an Epstein pattern, which I don't want to take credit for it. Many more passes, a little bit lower fluence, so we control the amount of energy. So it's all about delivering energy. So you're going to deliver energy and control the energy delivery through fluence setting, number of passes, overlap of passes. So we do a lot more passes, a lot more overlap. For males, we almost always do the forehead as well as the cheeks, from sideburn to sideburn, over the cheeks, nose, other side of the cheek. For women, tragus to tragus, basically earlobe to earlobe on the surface. And we'll typically do somewhere around 70 pulses, 60 to 80 pulses, depending on patient's face size. With overlap, we do one overlap. We also treat chalasia using the same way. We have a paper in process. Laura Perriman does it on the lid margin itself. We're doing it periorbitally with good success, and we get fairly close, but obviously with shields on, with those patches, not on not on the lid surface itself. And again, I'm not as big a fan of laser grade shields, the metal shields, simply because it takes more time, and the only way to make IPL profitable is to do it very rapidly. The same way cataract surgeons, when I first got started, took an hour to do an intracap. Now, cataract surgery, if you're a really good surgeon, you're finished with most of it in 6 minutes, or maybe in some cases less. So we're trying to maintain 15-minute spacing for patients, because it's the only way to make it profitable and reasonable for the patient.
Okay.
Comprehensive answers.
On top of that, we're going to keep going because people keep responding to your answers. What is your interval of treatment? So you've done an IPL, when do you do the next one?
Average 4 treatments a month apart. Some patients do well with 3 treatments, but that becomes logistically very difficult. So we basically charge patients for 4 treatments upfront as a package, and I don't stop at 3 because it doesn't hurt to do it. Occasionally we'll suggest an additional treatment. Initially I was doing it at no charge. I do now charge a nominal amount for the additional treatment, with rare exception. If I have a patient that is financially limited, we just do what we need to do. But that's the protocol, and we'll do it as quickly as 3 weeks and as much as 6 weeks out.
Okay.
Between.
Okay. How often do you treat meibomian gland deficiency patients with low dose doxycycline, and how long do you keep them on it, and at what dose?
Great question. So 50 milligrams BID, doxycycline monohydrate, hyclate and monohydrate work differently. So monohydrate seems to be much more effective for me. So 1 month BID, 50 milligrams, and then the following 2 months QD once a day. With food, avoid dairy products. More males than females. And the reason why is I'm concerned about overinfection, yeast infection, and so on. Much less so now with patients that are getting IPL. I find IPL to be a more natural way of doing that, with even better outcomes. I find doxycycline to be helpful, and sometimes I'll increase the dose to 100 milligrams up to twice a day if they have very, very severe staining. Doxycycline, in addition to be anti-inflammatory and inhibiting MNP9 activity, also inhibits PMN chemotaxis, which is one of the root causes of staining. So when patients have fairly dense staining, I'll add that. There's overlap in mechanism of action with omega-3s, but it's synergistic. So generally, it actually is even more helpful in controlling, dense staining. So yes, but not as much as before.
Okay. Have you heard of Therma Eye IPL? If so, what are your thoughts?
I've heard of it. I don't know very much about it, so I don't really have any formed thoughts. I assume it's some form of heating. And, again, as long as the heating is controlled and you're not causing potential damage, the last thing we want is, a sensational story about an optometrist, cooking someone's eyeball like an egg, with the timer broken. So, as long as it's safe and effective, you know, I'm okay with it.
So we do have a question. If I wanted to start a dry eye clinic or just a dry eye practice and I don't have unlimited funds, where would you recommend starting? What equipment, treatments are a good starting basis?
Well, I get asked that all the time. First of all, your office is filled with dry eye patients, which we don't realize because most people say, "Oh, I'm getting older, and that's why my eyes are bothering me," and they don't really recognize that what they're experiencing is what we call dry eye. It's not really dry eye, it's an unstable tear film and difficulty in functioning. By the way, forgive the mess behind me. This is my mess room here, so. I just looked in the mirror and I went, ah. I do get asked that, a lot. So the first and most important thing is a questionnaire. I use the speed test, and you can download it for free on the internet. Just look up speed dry eye assessment. And what's great about it is if you have one of your assistants, a technician, a front desk person, whatever, deliver it to the patient, have the patient go through it with them and then score it right then and there. You can then bring dry eye as an issue to the patient's attention. Mrs. Smith, you score really high on this dry eye assessment. I'm going to mention it to Dr. Epstein. In terms of diagnostic equipment, again, and it's not because it's sponsored by Oculus. You really need a way of communicating, and to spend $10,000 on Meibography, versus $15,000 or whatever the cost of an Oculus is these days, you're shortchanging yourself because we paid off the Oculus in almost no time at all. We charge for an initial visit at 99203 or 99214. If it's an existing patient. And on top of that, we charge a fee for imaging and assessment. Basically we call it a dry eye workup. And that's cash pay. That's in addition to that. And the patients are told up front that money covers the cost of imaging and the time that I spend discussing it beyond what would be reimbursed by insurance. So I strongly recommend the Oculus, which I think is great. There are other instruments that do similar, but I don't think quite as advanced as the Keratograph. And again, a communication tool. Patients are not going to go for treatment, and they're much less likely to comply unless they understand what's going on with them and take it seriously. So empowering and educating is, I think, critically important. In terms of treatment, I would, again, with limited funds, I would definitely go TearCare because it's really low cost of entry. I would get some triglyceride-based omega-3, which is typically PRN, DE3 or Nordic Naturals EPA Extra. I prefer PRN because I have more experience with it. And I think it's, in my estimation, a little bit less expensive for patients. I would get hypochlorous acid, you get on www.gethighclear.com. I did that really quickly, gethighclear.com, and order like one case of it or something like that. You sell at point of sale to the patient. So we have a small cabinet, and I have a checklist which you'll have access to, and I bring it to the front desk. The front desk basically says, I'll get everything for you, and I tell the patient up front that we have it simply because if you leave without it, chances are you won't be using it. That's been my experience, which has been my experience. So patients will actually buy things from us because it's right there and it's convenient, and convenience is important. So that's a profit center. And then once you get going, I would add a Luminous M22 Optima M22, as the next thing that you buy. And again, all those things pay for themselves. The TearCare pays for itself. The Optima pays for itself. At some point, some of this will be insurance reimbursed. I know TearCare is looking into that, or Sight Sciences is, and it'll be quite profitable because insurance will pay for it at reasonable amounts or reasonable rates. Right now, it's all cash pay, and you'd be surprised how many patients say, oh, my patient population wouldn't be able to do it. Trust me, they have problems. They spend money on Starbucks. we think we're not worth it, so we say, oh, they can't do it. The patients do it. They do it. Anyway, that's what I do.
All right, and that was a good answer. Okay, our next one, the beginning portion, you kind of addressed this in the beginning. They were asking, can you go through your new patient dry eye evaluation? You kind of already touched on that in the beginning of this webcast. The second portion, though, they're asking, what are you doing in addition to your Oculus Keratograph IVM on these patients?
Okay, so the Oculus 5M, every single patient, I already went through, mybography, non-invasive rectal time, and so on. We also we have a LipiView 2, and we do interferometry and we do blink analysis. The interferometry is, both are of value, but interferometry is very, very valuable to me because it gives us lipid layer thickness, so we can see, you can quantify the thickness of the lipid layer and also get a good sense of cohesion and quality of the lipids. Patients brought into the room, I begin a discussion with them, ask them to step through their day with me, ask how long they've been suffering, who they've gone to, what they've had, and get a basic history, beyond what my technician or assistant has done, because I want to interact directly with the patient. There's a lot to be said for that direct interaction. And then I'll swing the slit lamp over. I have these brand new, we just expanded the office, so I have we call it Dry Eye Land. And so it's its own little dry eye center in and of itself, where we have all the dry eye testing, and I have 2 lanes just to me, which is great finally. And I'll do fluorescein staining, I'll do lissamine green staining, not always, and I won't do it on every single patient, but I do it on a fair number of patients. And sometimes we'll do photographs as well. And then I kind of review everything, go over the checklist that, again, you'll have access to, kind of bring it all home, ask them if they have any questions, lead them up front. They get what they need. We're rescheduling them in 6 weeks. And, patients, I think, leave with a sense of hope for a condition that for many patients has been hopeless before. And I know if you're saying, I don't have those dry eye patients in my practice, number one, you do. And number two, once you start doing it, you build it, they will come.
All right. Can you talk a little bit more about the role of your technician in your practice, and do you have a dry eye counselor or someone to help ensure that your treatment gets implemented?
That's great. Great question. Great question. Brilliant audience. This is a tremendous audience. So I have 2 techs, one of whom came to us because he wanted to do dry eye. He's a certified tech, really bright guy. And I have Donna, who's been with me for, almost from the beginning. I think actually from the beginning. And Donna's just absolutely phenomenal. So they do pretty much everything. I honestly don't. I think I do know how to turn on the Oculus and the LipiView. I'm good friends with Barry Iden. Barry, I love Barry's, just such a nice, bright guy. And we were actually at a meeting together, and someone had commented on using the Oculus. I said, Barry, do you use the Oculus? Do you do any testing? He goes, I don't even know where the on switch is. So, technicians make you so much more efficient and allow your time to be so much more valuable in terms of contact with patients. The other thing that a technician or an assistant is great for is, I have no issue with quote unquote selling, and forgive the term, I hate the term selling, I'm not a selling guy, but I have no issue in selling IPL. No issue whatsoever. And I explain to the patient what it is and what the benefits are, and it's simple. And patients go, well, when can I do it? When can I sign up? LipiFlow, different story. Expression, for some reason, is much more difficult. So one of the things, I was a center director for TLC many years ago for probably about 6 months in Garden City, and I learned that the role of the LASIK closer. So the ophthalmologist figured out that they were terrible salesmen early on, so they had someone who'd come in and say, well, Dr. Donenfeld recommends that you have laser, blah, 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 and this is what it's going to be, and this is what it's going to cost. And the same way that someone in your optical will sell $2,000 worth of metal and plastic worth 25 cents with an Armani label on it to a patient. Not that I'm diminishing the value of Armani, by the way, by any token or stretch the imagination, but I'll have someone come in and say, Dr. Epstein recommends that you have LipiFlow or tear care, and we'd like to schedule it, whatever. This is what it will cost, and this is what it entails. And I would say 9 out of 10 times, it's done. and I know I can't do it because I'll go like, I'll start whimpering like a dog and look away, and I can't make eye contact. It's optometric guilt. So that's another good reason for a tech.
Would you please discuss the impact of dry eye on the contact lens dropout rate?
Yes, many of the patients, that's a great question. Many of the patients we have, first of all, contact lenses, as they've gotten more complex and moved from conventional hydrogels to silicone, have become much more challenging for the ocular environment. In terms of relative, size, we sometimes forget that the tear film is about this thick and the contact lens is about this thick. So the contact lens goes, and when you stretch an already dysfunctional tear film becomes unstable. Contact lens is exposed to the external environment. Surface becomes hydrophobic. Lid's going over that, the lid wiper. You end up with all kinds of problems. Patient becomes uncomfortable. So essentially, a deficient dysfunctional tear film, which is increased, by the way, over the let's see, when were soft lenses introduced? 1971. In 1980, when I was, starting to fit conventional hydrogels frequently, dry eye was never a complaint. I had young patients, I had old patients, never heard any complaints about dry eye. Reason why was twofold. Number one, hydrogels are actually relatively hydrophobic if they don't dry out. And number two, the Apple II wasn't introduced until 1977, and the IBM PC in 1982, and the iPhone in 12 years ago. So tear films were much more stable, back in the 1980s, so we didn't have comfort issues. So we tend to mistake the reason for contact lens dropout and contact lens discomfort in many cases, and think it's the contact lens or the solution, when in reality we're not looking at the tear film and tear film stability. Number two, the materials have really been crap. I mean, frankly, the material design has been great from a physiologic point of view, passing oxygen and gases, but it's not proven to be that valuable in decreasing complications. Number one, decreasing extended wear has been probably much more effective. And number two, until relatively recently, DT1, major step forward in terms of wettability, but more importantly, the new Infuse is just mind-boggling because it now works with deficient tear films. And you're going to see more and more technology coming from companies that address dry eye if we don't manage to recognize it and address it early on. But that's a great question. A lot of dry eye in contact lens wear is a lot of dropout is because we're not addressing the underlying tear film instability.
Okay. So in an earlier question, we asked about how you utilize your technicians in your practice. We have someone who's asking, how do you get over the hurdle of patients who only want to hear from the doctor? And
okay.
Even though your technicians are specialized, how do you get over that?
Well, everyone deserves a life, although I don't know what happened to mine, especially these days. I don't think anybody has a life anymore because we're trapped in our little mini cages thanks to COVID. Read my editorial this week, by the way. It's going to be the solution to all the problems, all of them. So anyway, patients, if a patient there are some difficult patients. Some patients need to hear it from the doctor. That happens very, very rarely. If you set the practice up properly and there's a hierarchy, the patient feels that they have been touched by you and you are in control of the situation, and that there is an intelligent pattern and flow to the process. And the last thing you want to do is you want to turf a patient with critical stuff to a technician, because the patient's not coming to see the technician, they're coming to see you. So it's just the way you present it and the way you organize. Again, it kind of goes back to what I said before. The key to success or failure is figuring out patient flow in your office. If you can't figure out patient flow, you're going to never really have a successful practice. If if I see you at a meeting and, in 5 years when they start again, and you say, maybe 8 years, whatever, and you say to me like, I tried to do what you said, but, I couldn't shoehorn those patients into my 15-minute exam slots. I'll say, you can't shoehorn a patient into your 15-minute exam slots. I can tell you that, generally speaking, with the exception of scleral lenses, my time generates as much income as my wife or my associate's time, who are not seeing dry eye patients, although my associate does see dry eye patients. But And again, I'm seeing patients in some cases on an hour slot. So don't think that it's not profitable because it takes more time. It actually should be more profitable if you're doing it right, which means that there are out-of-pocket uncovered services being charged to the patient, and that you're doing stuff that makes a difference in their life that justifies the additional cost.
Well, this is all the time we have for tonight, and if you missed part of the webinar or if there's anything you would like to go back and review, you will receive a link to the recording in the next week and also the handouts that Dr. Epstein is going to provide. And thank you for everyone who sent in questions, and thank you everyone for joining us, and thank you, Dr. Epstein, for this live question and answer. Are there any final thoughts you want to leave the audience with?
Yeah, actually, first of all, I wanted to thank everyone for taking time, to join us tonight. I like I said, sharing information, and hopefully you found this interesting. I really urge you to think about the possibilities. I mean, a lot of you do. Dry eye is a hot topic. Avoid the noise. There's a lot of confusion. It's not that difficult. It's not a million different things. I mean, if you get into the technical and scientific stuff, it gets, confusing. But to start out and be successful, you can keep it relatively simple and be very, very successful. You don't need to see the most insanely complex patients. And finally, I actually want to thank Oculus for sponsoring this. I mean, it was very generous to say, hey, we want to get you on to answer questions. I know during your masterclass presentations, there were a lot of questions, and God, we had a lot of questions. And I answered, as many as I could, but there were more. Oculus, stepped up and was nice enough to do that. And, if you're thinking about getting an Oculus, and again, this is not, I unfortunately don't get paid by Oculus, so I'm not, I'm not on a commission basis, nor would I want to be, by the way. But, if you're thinking of it, think of it, like this is a good investment now. Like I said, we paid it off in literally months, and it transformed the practice. So, I highly recommend the technology and the fact that they support, and I've called up, say, help me, this isn't working, or my thing is whatever. So anyway, I wish all of you success, stay safe, and we will get used to this. I'm not going to say, I don't think it's going to end, but get used to it and stay indoors on election night. Stay indoors.
All right. Thank
Bye,
you very
everyone.
much. And this concludes the presentation. And on behalf of Oculus, we hope you have a good night. Thank you.
Thank you, guys.